Hello everyone, my name is Sherene Shalhub. I am a vascular surgeon at the University of Washington, and I will talk to you about how do we treat acute type B aortic dissections. Over the next 15 minutes, we will talk about type B aortic dissections and the complication-based approach for how we treat them. I'll discuss with you how we use stent grafts, as well as what happens after discharge from acute type B aortic dissection admission. And this is by no means an intended talk to cover every iteration of type B aortic dissection. It is simply to give you a solid foundation as you begin to understand what this entails. At this point, you are quite familiar with the classification of aortic dissections, and I'm specifically talking about type B aortic dissection according to the Stanford classification, or type 3A and 3B according to the DeBakey classification. I also want to bring to your attention that the newer definition of aortic dissection by the Society for Vascular Surgery and Society for Thoracic Surgery includes aortic arch beyond the innominate artery into the definition of type B aortic dissections. In terms of timing, I am specifically talking about people in the acute and subacute phase. So these are people presenting anywhere between 1 to 30 days post-dissection. Here I want to remind everybody of the double lumen configuration, or the double barrel configuration of an aortic dissection with a true and a false lumen. That happens because the blood has dissected into the layers of the wall of the aorta. And in yellow, you can see highlighted here is a three-dimensional reconstruction of a aorta from a CT scan, and you can see the dissection here. And you'll be seeing quite a few of these throughout the slide, so I'm just pointing it out now. And on the right, all the way on the right, you can see the two yellow arrows pointing out to aortic dissections on what we call an oblique view and an axial view of a CT scan. You'll be seeing some of those images as well. This is another graphic, again showing you the true lumens, again double barrel configuration of a dissection. And the picture in the middle here shows you an intravascular ultrasound. And I will pause for a second and orient you here on the right side. You can see this, again, this is a cross-sectional image using the ultrasound that we have put into the aorta. And you can see the two channel. If you follow my arrow here, you'll see the true lumen and then the false lumen. Please note how mobile this septum is here in the acute phase of a dissection. So you can see again that the intravascular ultrasound probe is inside the true lumen, and then you can see as we move along the aorta, you can see the septum moving along the way. Now we'll switch to management. Management principles revolve around two concepts: medical therapy, which everybody gets, and surgery. Medical therapy is focused on blood pressure control at the time of dissection and in the long-term follow-up. Surgery is indicated based on complications. These complications involve rupture, malperfusion, aneurysmal degeneration, or persistent pain, and I will go through all of these. Aortic rupture in type B aortic dissection is a clear indication for surgery. This presents as chest pain or left shoulder pain and sometimes upper back pain. You can see here on a CT scan where the yellow arrow is pointing, this is an aneurysmal aorta that had dissected and ruptured, and you can also see where the white arrow shows the blood in the chest cavity. All the way on the right is the three-dimensional reconstruction of this aorta, and you can see the aneurysm formation as well as the leaking of blood outside the aorta itself. So this is an emergency and requires emergency surgery. Malperfusion is another indication for emergency surgery. This happens when that intimal flap, the very mobile one that I showed you, can either block off the flow through the arterial branches of the aorta either permanently or intermittently. This can affect any of the branches of the aorta. So that includes the mesenteric arteries. These are the arteries that feed the stomach, the liver, and the intestines. The renal arteries, these are the ones feeding the kidneys, as well as the legs. Here's an example of mesenteric malperfusion. That means that the arteries feeding the stomach, the liver, and the intestines are not getting enough blood flow because the intimal flap from the dissection is blocking off these arteries. This presents as abdominal pain, usually severe abdominal pain, in addition to the chest and the back pain that we discussed earlier. The pictures on the right now show you after surgery how the true lumen now is expanded because we were able to put in a stent graft in the thoracic aorta higher upstream from that, and I'll show you exactly how we do that. But you can see that post-surgery, the true lumen is now open and we've restored the blood flow to those arteries. Another form of malperfusion that happens with aortic dissection is called acute limb ischemia. This is again similar to how I showed you the visceral malperfusion. The dissection is cutting off the blood flow to one or both legs. This presents with sudden onset leg pain, accompanying the chest pain or the back pain that I mentioned earlier. And this picture on the right hand side is a picture of somebody's waveforms, meaning we're measuring the waveforms in their arteries to see if they have blood flow. And you can see that clearly the right leg is different than the left leg in terms of the lack of blood flow or the flattened line. So this person has acute limb ischemia. Next, we watch for rapid expansion or aneurysmal degeneration. In a sense, we're looking for aneurysms. An aneurysm is the swollen part of the artery, meaning that when we have dissections, the aortic wall is weak and can expand and become an aneurysm. So certainly if this is happening rather quickly after the dissection, that is an indication to treat. Lastly, refractory pain is also a reason to operate. And what I mean by refractory is that this is continuous pain despite best medical management. This is somebody in the hospital, we've admitted them, they're on blood pressure control, their blood pressure is well controlled, but they continue to have pain. And the pain is usually in the chest or the left shoulder or the upper back. So that is also a reason to operate. So now that we know why we need to take somebody to the operating room in the acute phase of type B aortic dissection, let's talk about how we fix the aorta. In this circumstance, we use something called TEVAR, Thoracic Endovascular Aortic Repair. The concept of this, if you look on the left, is that we are putting an aligner in the true lumen, and what that does is that it cuts off the flow to the false lumen and causes the false lumen to thrombose, with the idea that the aorta will, quote, remodel and shrink around the stent graft. If you look at the video in the middle, you can see that here's an animation of the wire going up, and here is the TEVAR coming up in the delivery device, and then we unsheath the device and that deploys the TEVAR. And if you look on the right, you can see the three-dimensional reconstruction of an aorta with a TEVAR after TEVAR deployment. And now you're wondering how we get the device up. So we do this via the femoral artery access, as you can see in the upper left corner. And if you look in the lower left corner, you can see what we see when we look at fluoroscopy, because we do this under X-ray. And then the picture on the right is the picture of my team and I, and the device is in my hand. You can see it's a long device, it's the size of a pencil, and this is what we advance through the femoral artery and then unsheath in the aorta. And we are able to get this device up through the femoral artery, and we use the X-ray machine. You can see here that we're looking through that and we're watching the monitor and to watch our device advance through that. And this is what we see in the OR when we're looking at the aorta under fluoroscopy. The dye colors the aorta and the arteries this dark blackish color, and you can see we can mark our arteries and our landmarks, and then as you can see on the left hand side we have the device that is still constrained and we position it, and then on the right hand side we have deployed the device, we've landed it where we wanted it to land. Now one thing you may be wondering is that it looks like we've covered the subclavian artery on the left, and this is true. Frequently this is something we have to do in order to achieve what we call a landing zone or a seal zone, and that actually takes out the left subclavian artery at its origin. So then you ask, well, what about the left subclavian artery? What do you do with it? Great question. For that, we have a left carotid subclavian transposition, and what that means is it's an operation in where we move the subclavian artery and attach it to the carotid artery. This is done via an incision on the base of the neck above the clavicle, as you can see with the white line, and then we dissect out the left subclavian artery, and then we sew it into the left common carotid artery. Usually we do this before the TEVAR if we have time, but if it's an emergency, we address it after the TEVAR. After discharge, whether somebody's medically managed or had surgery, the cornerstone of treatment is still hypertension control. Secondly, if somebody is smoking, we do strongly encourage smoking cessation because it is a pro-inflammatory agent and it is associated with worsening aneurysms. We also discuss an overall healthy lifestyle to incorporate daily walking and moderate exercise because we believe this improves the integrity of the aortic tissue, as well as subscribing to a healthy diet. In terms of other medications, one may be prescribed low-dose aspirin, and that is dependent on their surgeon. And lastly, we do recommend avoiding fluoroquinolones. This is a class of antibiotics that the FDA had issued a warning against because of its association with worsening aneurysms and dissections. We also have to create a care team that consists of a cardiologist, a primary care provider, and a vascular and/or cardiac surgeon. Additionally, if somebody qualifies for genetic testing and has indications as you were hearing about all day today, then they should be referred to have genetic counseling and testing. Moreover, this is a lifelong process. Therefore, we have to follow people's aortas over time with surveillance imaging, usually at 1 month, 6 months, 12 months, and then annually thereafter using CT or MR. And what we are looking for is progression of the dissection, either beyond the areas in which were dissected to begin with. We're also evaluating for any evidence of new aneurysms that may form, whether in the area that was dissected or in other areas that were undissected. And if somebody had a TEVAR, we're also monitoring for post-TEVAR complications. And ultimately, in a certain portion of the population, the entire aorta may need to be repaired. Here is an example of somebody who had a type B aortic dissection, and over 4 years you can see on repeated imaging that the aorta has been stable. It has not changed in size or configuration and have not developed any additional aneurysm beyond the original small aneurysm that had formed at the time of dissection. Here is an example of somebody who had an aortic rupture in the acute phase on the left, and then we treated him emergently with a stent graft. And you can see at 30 days after, we're looking at the stent graft. And in this particular person, the stent graft was not only life-saving, but it was also therapeutic because the aortic dissection healed entirely, and he almost had no evidence that he's ever had a dissection. So that was a remarkable recovery. At this point, some of you are wondering, well, what about TEVAR in people with genetically triggered aortopathies such as Marfan syndrome, Loeys-Dietz, and vascular Ehlers-Danlos syndrome? You are correct. This patient population has been excluded from the trials for TEVAR, predominantly because of our concern that the device will not fixate in the diseased aorta and will cause complications in the long run. That said, there are circumstances such as emergency circumstances with ruptures in which TEVARs are being used. Here is an example of a late complication after a thoracic endograft in a patient who had Marfan syndrome, which, as I mentioned earlier, is not the population we want to use stent grafts in. But what you can see is that at age 44, this was prior to the repair because she had an aneurysm related to the dissection and postoperatively. And then you can see 7 years later, the device was beginning to migrate. And at 9 years, she had a tear in the aortic arch related to that device, and then it retrograded into the ascending aorta. So she had a type A aortic dissection. So this again highlights the importance of close follow-up after these operations, even when the stent grafts are put in urgent type settings. Now, in contrast to the earlier case that I showed you in which the TEVAR resulted in remarkable recovery, this is a circumstance in which the TEVAR did not. There was definitely poor healing, and you can see how over time, you can, even to your naked eye, you can see that the TEVAR was just sitting there floating in the aorta over time. So these are circumstances that definitely warrant referral for open operations, and this is why follow-up is justifiable in these cases and why it's lifelong. This here is an example of why we have to think about the entire aorta, not just the dissected portion. In this particular circumstance, the person had an aortic dissection, which was a type B, treated with a thoracic stent graft, TEVAR, because they had malperfusion. Now they have recovered from that, but on close follow-up, we can see that the ascending aorta had an aneurysm, and this was very important to pick up. And we did two things. One is we set him up with cardiac surgery to have this repaired, and two, this person also, we obtained a family history and then subsequent genetic testing because of the family history, and it turned out that this patient had Loeys-Dietz. So again, this is why complete and comprehensive care is important, not just focusing on the type B aortic dissection alone. And lastly, there are circumstances in which something like a hybrid repair is appropriate. This is, for example, in the cases where we do a hybrid arch repair with a descending thoracic aortic TEVAR. The TEVAR in this circumstance is delivered from the open chest. As you can see, here's the picture showing the device, and as we animate, you can see that the device is being advanced into the thoracic aorta via the open chest, and then this allows the cardiac surgeon to sew in the graft directly to the aorta that has the TEVAR inside of it, and then this is what it looks like on the three-dimensional reconstruction. With that, we come to the end of this talk. I hope you have a good foundation now of understanding how we treat acute type B aortic dissections. Thank you for tuning in, and I look forward to having the live discussions later today.